Today, I will not present data from a study, but I will rather briefly highlight the journey of our research line on language and schizophrenia, starting from our seminal paper on the building blocks of language, addressing syntax and semantics, then moving to the most sophisticated aspect of language and communication, pragmatics, in the assess. Oh, you don't, no signal again.
There you are.
Okay. To the pragmatic assessment and remediation, and more recently this was integrated also with automated analysis and EEG analysis, all with the global aim to promote the implementation in clinical services of this type of assessment and especially remediation. So as already mentioned this morning, it all started with a collaboration between the Vita Salute University and especially the Ville Turro, this beautiful hospital where I work in Milan, and the Youth Pavia in this wonderful venue that you can see it. But I guarantee, when compared with Youth Pavia, we lose. But Ville Turro is still a really nice place in a park. And we started addressing syntax and semantics separately in patients with schizophrenia to an anomaly detection task. And at that time, what we found was that semantic abilities, at least compositional semantics, were relatively preserved in people with schizophrenia, while there was a specific impairment in syntactic abilities. Then we moved from our roots, going from to the pragmatic assessment. Why did we focus on pragmatics? Because pragmatics, it is the most sophisticated aspect of human communicative abilities. And in the broader perspective, it allows us to communicate and to understand each other. So among the linguistic domain, it is probably the one that is more strictly a measure of functioning, of communicative functioning. And we started with my PhD thesis by doing a comprehensive assessment of pragmatic abilities in a sample of people affected by schizophrenia. At that time, there was already attention in the literature on difficulties targeting these domains, but they were rather sparse and very few comprehensive assessments, including all the pragmatic domains. And what we found is that you can, if you look at each pragmatic domain, you can find the performance below cutoff in over 90% of people affected by schizophrenia. And when you look at the global pragmatic comprehension, there in gray, we still have 70%, 77% of alterations detectable, which is closer to the cognitive deficit that we know being a building block of core feature of schizophrenia. And more importantly, we also showed a direct impact on quality of life. So we went deeper in trying to assess the relationship between these communicative abilities and other domains of the disease, cognition, such as cognition, but also symptomatology. And yes, we confirmed correlations between these domains, but they are really not overlapping. It is worth to study it, to target it independently, especially in remediation, for remediation purposes. Recently, with Federico and Valentina, we performed a systematic review that was already mentioned by Stefano, who made my work easy here. Innovatively, we not only look at the association between these functions, but we weighted the relationship between them, finding that both executive functioning and social cognition are related to pragmatics, but their impact is different. It's different in the strength, and it is also different at the hierarchical level. So we have executive functioning with a smaller direct impact on pragmatic abilities and a stronger indirect impact on pragmatic abilities through social cognition, which also in turn has a direct impact on pragmatics as well as receiving from executive function. So when we consider pragmatic training, we have to consider all these levels, because the difficulties may either arise from the executive function level or from the social cognitive function level, or from both. Then we dig further into the relationship between daily functioning, proving that pragmatic abilities is a significant predictor of daily functioning, even when considering also the impact of other well-known factors such as neurocognition and theory of mind. Then, still with pragmatic assessment, we wanted to have a more fine-grained profile. And so we more specifically analyzed different types of figurative expressions, such as metaphor, idioms, and proverbs, in two specific types of tasks: verbal explanation and multiple choice. And we found that there are proverbs in verbal explanation that are particularly challenging. This is not surprising, and this is how we assess with the positive and negative symptom scales the difficulty in abstract thinking. And interesting metaphors supporting other studying in the literature was the one that was more related to the quality of life and functioning. Still wanted to find a more fine-grained profile. We also assessed verbal humor to a more specific task that maybe we can detail better during the lunch. And we found global difficulties in humor comprehension in people with schizophrenia compared to healthy controls. And interesting result on funniness appreciation, because patients tended to appreciate, to declare that they found the jokes more funny than controls did, independently of if they correctly understood the joke or not. And we have to dig more on this finding. The last part on the assessment, it is related directly to the promotion in clinical use, because our previous assessment lasted 45 minutes. So thanks to a grant financed by the Health Ministry, we, together with Valentina and Giorgio, Karens and Camillo, we developed a brief version which is able to capture in only 10 minutes all the main aspects of pragmatics. Then, once we characterize the presence of these difficulties and especially the impact on quality of life, we went on to develop a specific remediation program. And what we found, you have to look at the patient treated with the pragmacom in the light blue, and patient not treated with the pragmacom in pink. After the treatment and after follow-up, we found an enhancement not only in general pragmatic competence as assessed with the APACS and in metaphor comprehension, but also we also found a reduction of concretism as assessed by the PANS, but especially we found a significant change in quality of life. Quality of life measured with the quality of life scale, which is assessing also functioning, daily functioning. So the next step for pragmatic remediation are just, one is just starting our study frame funded by the PRIN, in which we will develop, among other things, a web version of the training. And then we'll hope with Giulia Agostoni, which is here in the audience, to be able to develop the pragmatic work, which is a pragmatic training specifically adapted for work context. Recently, we integrated with new approaches, thanks to Federico and Chiara here also in the audience. And so we went back to our origins from the building blocks of language to the pragmatics, but with a different approach. So here are the measures that were integrated in the analysis. And differently from what was already available, we used it to assess patients with chronic schizophrenia, and we were able to identify 2 clusters of linguistic abilities, and those were directly related to both symptomatology and quality of life. And with this approach, I'll invite you to see our poster downstairs. Finally, the neurophysiological signature that we are just starting to address with 2 main aims. One to identify the correlates of pragmatic abilities, and for that, please see Giulia's poster. And the other one just starting is to test if the altered neurophysiological patterns associated to pragmatic vulnerabilities will change through the pragmatic training. So we'll have a longitudinal assessment. As I said, all these as the goal to promote implementation in clinical practice. So the take-home message is really simple. We wanted to prove that pragmatic difficulties are a core feature in people with schizophrenia. They are related but not overlapping with the neurosocial cognition, and so I'll be pleased to continue the discussion during the lunch. And most importantly, it can be remediated through a specific training, so it's not static. And our next challenge are to go more in depth into the profile, thanks to the new available tools, which can lead, among other options, also to optimize intervention and to map neurophysiological markers that can be used, that can promote potentiation strategy, that can be a treatment target, for instance, for TMS to improve functional outcome. And thanks to direct collaborator in this study, in here, Valentina and Giorgio Carat San Camillo, and thanks, of course, to the all clinical schizophrenia research and clinical unit, and especially to Giulia Agostoni and Jacopo Sapienza, Federica Repaci, and Federico Pacchioni, who are here in the audience today, and thank you all for listening.
Thank you very much for your retrospective and retrospective presentation. That is the best way to go on in this research. Progress over what you have already established. I can, with that, this trip in linguistic field has been a stable characterizer of our work in the last 15 years. And is in continuity with cognitive remediation, social cognition, and so on. But every step we add, we do really have better results on the clinical outcomes and the recovery possibility of our patients. And I think that before the last questions, we can conclude that today in this Italian chapter session, we have seen that a lot of things can be developed and even probably in brief times to use the discoveries of language science and to bring it to clinical effective systems to have better outcomes in our patients. So there is a question? No? 3, 4.
Very much, Dr. Bosia, and very nice to see again positive results. By your findings, those of the previous speaker, it seems that more the better, right?
Yeah.
Give these patients treatment, then give them a lot of treatment. But we know, I'm sure this is the case in Italy as well, it's also Netherlands, most countries, resources are very limited, especially for chronic patients. So how can we progress? Would you say that this remediation intervention can maybe be done by medical students, volunteers, family members, or should we rather think about maybe automatization, digitalization? Which road would you recommend?
Yes, thank you for your question. And within the clinical working group in Discourse that will be presented by Susan Russell in the afternoon, we are proposing a position paper on how to promote and enhance this type of remediation in treatment of schizophrenia. I believe that one first thing that we have to do in order to access, to increase access, is to increase awareness about the program. Even before deciding on how to increase the resource, because right now, this is in Italy, this aspect is not studied in during your psychiatry residency, for instance. So psychiatric training, don't know. So we have to increase awareness about what mental health service in mental health people working in mental health and in people with the disease. As for your suggestion, they are both great. I was thinking more of a combined remote delivery treatment. Actually, with Giulia, we hypothesize a treatment in which the first session is in presence. So to create the group and to explain, to inform what are the goals and to explain how it will work. And the other section will be delivered remotely. Of course, the platform is also an opportunity. It's much more, we need funding to do the platform one rather than the online. And yes, we have a great experience also with psychologist trainees working with the program.
if I can add, and this is a topic that is very treated since a long time, also from the School of Operation, and is that also professional rehab therapists are involved in this kind of, of rehab. Then I think also that what Marta says is about awareness is quite important, and to be able to pass this to the mental health workers, because you said the right things, the more the better. Okay, so if in every gesture or speech that you have with patients, you consider these aspects, you are doing rehab. That's the way we organize our daycare facility. Therapists of rehab know that a patient is not able to make a cake because he has no motivation, or he has no memory, or he has no attention, and also doing a simple thing like that and helping him to do it, he is doing also cognitive remediation, because he chooses what needs to be to improve, what strategy is needed to improve his performance. So the more we know, the more social workers also know about this, the more we can do, I think. And then developing brief instruments of assessment and therapy like Marta is doing.
You have time?
Yeah.
One question.
Really fascinating, Marta. And also following up the question that Edith asked, the resource problem. And linking back to the data that he showed that patients are heterogeneous in some sense. You can find some clusters. Some patients form some subtypes and others no. Do you actually think we can select subtypes of patients and apply pragmatic communication to them? What's your thinking?
Yes, absolutely, I do agree, and that's what we do in our Center for the Neurocognitive Remediation Program. For instance, of course, it is individualized, it is computerized, and it is individualized on the specific need. That type of assessment could also address the rehabilitation. So maybe some people do not need it, or maybe some people need more specific modules on metaphor and not on off-topic verbosity. So yes, that's, yeah.
We did it originally with cognitive remediation. We were the first to attribute exercises and also to analyze results on a sort of personal passport of the patients. That is, if you had attention particularly impaired or executive function, you did more exercise on that, because in the same time of exercise, you do not exercise what is already normal. I think that also in this field it could be absolutely the same.